Those of you on Zoom, can you please unmute yourself and tell me if you can hear me? Just say yes or no.
Yep, I can.
I can hear you as well.
Okay, Emily, you can hear me?
Yep, I can.
Okay, thank you. If the slides don't move, say something, because if you do a text, I probably won't see it. So here are the slides. Okay, now tell me if they move. Are they moving?
Yep.
They're
Yes.
moving. Okay, very good. All right, we're going to get started then. All right. Good morning. Nice to see some of you back from quarantine. And hopefully we all stay off quarantine. I don't know if any of you heard, but Western schools are now closed. For the next 2 weeks, they just had too many cases. So Western schools here in Parma, Spring Arbor area, all closed. They were doing so well too. So they're all online for the next 2 weeks. And my wife came home and she's just crestfallen. She hates this quarantine stuff. So I guess you could say she feels your pain or something like that. All right, we are talking about antifungals. We will hopefully finish the antifungals today, and then we will hopefully talk about antivirals, and then move on from there. Does anyone have any questions about anything we've talked about before? No? No questions? We're Zooming at the same time, so if a person on Zoom asks a question, you won't hear it because I can hear them in my little earpiece here. But if they ask a question, I may stop all of a sudden, try to answer a question. So I'll make reference at time to the board, so please try to, I know for you guys over there it's hard to read because it just gets smaller the further away you get. Also, the green doesn't show up all that well sometimes. I'm trying to use darker markers, but oh well, way it goes. Haley, how's Karis doing? Is she feeling all right? She's feeling, no symptoms? No? Okay, that's good to hear. All right, lab books are there for those of you who turned your lab books in. On Wednesday, rest of you, if you want to hand them in, I will take them before I leave. Very good, let's have a word of prayer, then let's get started. Lord, thank you once again for bringing us together. We pray for those who are quarantined. I know it's very lonely for those being quarantined. Lift them up, encourage them. Thank you for people who take meals to those who are quarantined. Thank you for students who come by and talk through window screens and encourage people who are in quarantine. It really means a lot to quarantine students. And for the rest of us who are here, please, Lord, help us to live wisely, smartly, and stay away from quarantining. Thank you for this beautiful place, for this mission, for these students, their mission as healers, to train as healers. We pray now, you watch over us and sustain us in Jesus' name. Amen. Amphotericin B. Amphotericin B is a polyene. It binds to ergosterol in the membranes of fungi. Fungi, remember, do not have cholesterol. They do use sterols, but the sterol they use is ergosterol. Ergosterol. Amphotericin B binds to ergosterol, creates pores. Those pores cause the membrane to leak. The leaking of the membrane will cause the fungal cell to die. The selectivity of amphotericin B for ergosterol over cholesterol is absolute. It will still bind to cholesterol and it will still cause pores in our cells, our membranes, but not nearly as efficiently. So this drug is toxic. The organ that feels the toxicity the most acutely is the kidney. So to get over this, drug manufacturers have made versions of it that aren't as toxic to the kidney. They have tried to package it into liposomes. That's your liposomal amphotericin B. Unfortunately, this one, of course, is most expensive. And then an amphotericin B lipid complex. Neither one of these is as toxic as the bare bones amphotericin B, shall we say. Then there's a colloidal dispersive form, has a lot of protein in it. Also a trick clinicians will use is to sodium load. Before the patient gets the amphotericin B, that tends to protect the kidney. So there's tricks you can use to protect the kidney. Still, your patient is going to suffer some decrease in glomerular filtration rate with this drug. The renal toxicity of this drug is dose dependent. It's dose dependent. First thing you experience upon infusion is an infusion-related reaction where the patient will usually get chilled. Remember, you can fix that by having a blanket ready, throw the blanket over them. Also, patients will typically experience headaches on this medication as well. You may also get muscle spasms. The muscle spasms are usually due to the chills. If you put the blanket over them, that's less likely to occur. Because it affects glomerular filtration rate, you'll tend to lose magnesium and potassium. So you have to keep that in mind when you're giving them fluids. Make sure you give them plenty of magnesium and potassium. Also, you're going to want to increase the magnesium and potassium in their diet as well. Do you take this drug orally? Infusion, IV infusion. Again, renal toxicity can be decreased with proper hydration, but you're going to pay attention to hypokalemia, hypomagnesemia, and if hypokalemia, hypomagnesemia become an issue, then you're going to start looking for arrhythmias. Other side effects, usually more a function of intrathecal administration, will be seizures and neurotoxicity of some sort. That's if you're administering it intracisternally. And this drug is the drug of choice for severe meningitis, fungal meningitis, usually caused by Cryptococcus neoformans, which causes cryptococcosis. Okay, so as we said before, you can, nephrotoxicity, you can use acetaminophen or hydrocortisone to pre-medicate your patient to attenuate fevers, chills, rigor. Some patients get rash. That's 15% of patients probably. So minority, but patients do get it. That may be due to a histamine release. You might be able to fix that by pre-giving them diphenhydramine. So sodium load to attenuate nephrotoxicity. Nystatin is always topically. Nystatin is used a lot in veterinary medicine. There's a hoof disease horses get. It's called hoof thrush. If you've seen a horse hoof, you can't miss it. It's this grayish, yellowish film that you get on the hoof, on the frog, it's called, of the hoof. Any horse enthusiasts in here? Oh, okay. If you've never seen thrush, it's really common. It's really common because the horse, especially if they've been in a field that's muddy and they're around and that gets wet and it stays wet, you'll see thrush. And nystatin is used for thrush. And it's kind of a mess to administer. It's oily and it's a lot of people, they won't use gloves when they put it on. And they'll get it all over their hands and then they'll, or, that sort of thing. And that, yeah. Anyway, drug of choice for your cryptococcal meningitis and infections caused by dimorphic fungi if they cause meningitis usually, or a drug of last resort, because it's pretty toxic. You don't want to give it unless you really have to. Any questions about amphotericin B? All right, 5-fluorocytosine. This blocks DNA synthesis. It is effective only against a narrow range of organisms. So it's deaminated to 5-fluorouracil by fungi, and that then gets incorporated into metabolites that interfere with the synthesis of nucleic acids in fungi. It's never used as a monotherapy. It's always used in combination with other drugs, most commonly amphotericin B. You use it for severe systemic infections. It's given orally typically. It can be given intravenously. There are intravenous preparations of it if the patient's too ill to take it by mouth. It is very nicely distributed in the central nervous system. It's excreted by the kidneys. So if your patient has decreased renal function, you have to drop the dose. Biggest adverse effect is myelosuppression. So you get decreased platelets, otherwise known as thrombocytopenia, decreased red blood cells, anemia, neutropenia. What's neutropenia? Neutrophils, neutropenia, decreased. Thank you, neutrophils, decreased white blood cell counts, decreased white blood cell counts. Patients may also lose their hair on this drug. Alopecia may be another side effect. Some patients have GI complaints. Those are not very common though. If they do get GI issues, they tend to not be very severe. So you're going to check your CBCs with this drug. You use it for severe infections in combination with other drugs for either long-term infections that are stubborn, hard to get rid of, or for severe infections, never used as a monotherapy because of resistance. Questions? About 5-fluorocytosine? Nope. Good. All right. Azoles. Azoles are the mainstay for antifungal therapy. Many of these are available over the counter. So there's two groups of azoles. There are the imidazoles. Imidazoles are almost exclusively used topically, with the exception of ketoconazole. And they're the triazoles, which are used for systemic mycoses. And these are given orally. There are intravenous versions of them as well. Essentially, all of these here are just given topically. They're just used topically. So miconazole, clotrimazole, those are available over the counter. Lotrimin, that's clotrimazole. Mycotin for athlete's foot comes as a spray. That's miconazole. And then these come as various products for ringworm infections and things like that. Those are your imidazoles. All azoles inhibit ergosterol synthesis. They inhibit ergosterol synthesis. So they inhibit the 14-alpha demethylase, which is an enzyme involved in the conversion of lanosterol into ergosterol. Lanosterol is the precursor to cholesterol synthesis in our cells. In fungi, lanosterol is converted to ergosterol instead of cholesterol. And so the unusual enzymes are a target for antifungal therapy, in particular the azoles. So let's talk about each of these particular drugs. Fluconazole is probably the most widely used of the azoles. It's very well tolerated. How many of you have heard of a drug goes by the trade name diflucan? Diflucan is really heavily used. It is an oral treatment for vaginal candidiasis. And I'm sure all of you have at least heard of vaginal candidiasis. So this drug is given orally. It's a one-shot dose. Of fluconazole. And essentially it works very well. The drug, once you take it, is absorbed extremely well and very, very widely distributed throughout your body. And a one-shot dose like that will give you very high concentrations with cervical and vaginal secretions so that you treat candida infections extremely well. Candida is a species of yeast that causes so-called yeast infections in women. So this drug, very effective against Candida species, very effective against Cryptococcus neoformans, and also against Coccidioides immitis, which causes a systemic mycosis. And it's less effective against molds Candida krusei, which is starting to cause a lot of systemic candidal infections in hospitals, is inherently resistant to fluconazole. So this drug, generally well tolerated, but some patients will get rashes. These drugs are metabolized in the liver. So some patients may show hepatotoxicity. If your patient has low liver function, then you really want to watch for hepatotoxicity. You might even want to consider reduced dose. Also, all azoles will show drug-drug interactions because they inhibit enzymes that are involved with drug metabolism. So if someone needs to go on an azole, always check their med charts and look for drug interactions. That's a biggie. It's eliminated in the urine. Your vulvovaginal candidiasis, they just require a one-shot dose, hence diflucan. Not all Candida species are susceptible to it. There are very good commercially available susceptibility tests for fluconazole. You get a culture. Candida, fortunately, in culture grows very quickly. And you can put it in literally a tube, grow it, and get a susceptibility test overnight. And yes, your patient will have to suffer maybe one more night, or if you give them the diflucan, then if they come in maybe a couple of days later and say, this is not working, give a susceptibility test that was ordered to be able to say, yep, you're right, it's not going to work, so let's try something else. Itraconazole. Itraconazole essentially is the next step up from fluconazole. This drug has a broader spectrum than fluconazole. It's also more toxic. So you can see it has activity against Candida species that fluconazole typically does not affect. And it's also very effective against many other morphic fungi. So it's effective against histoplasmosis, it's effective against blastomycosis, it's effective against other types of mycotomas and things like that as well. Doesn't do a very good job for molds. Granted, these types of infections you're only going to see in patients who are immunosuppressed. But otherwise, this drug is usually first line for systemic mycoses. This drug is a negative ionotrope. What's that mean? Can anybody tell me what that means? Have you heard that term before? No? You haven't heard that? Okay. Ionotropies, negative ionotropy means it decreases ion transport in heart muscle cells, in cardiomyocytes. So it's going to decrease the heart rate and it decreases the rate of conduction through the heart. So it's contraindicated in patients. Ooh, I'm sorry, I have a apostrophe. Okay, that apostrophe is wrong. That's a plural. I don't know what possessed me to put an apostrophe there. Scratch that out, please. That's bad grammar. Patients with heart failure. Contraindicated in patients with heart failure. Hepatotoxicity, put a little star next to this one. That's the one you're going to look at the most. If a patient's on this drug, you want to be checking liver panels, liver enzyme panels. So because of its negative ionotropy, you tend to get some QT prolongation. In most patients, it's benign. However, if your patient has a pre-existing arrhythmia, then you really need to watch this. So that might be something you might even want to just pre-order an EKG. Might be worth it to save your patient's life. Oral solution, especially first dose, will tend to cause diarrhea. Some patients withstand this drug really well. Others are off to the loo often with this drug. So that's going to vary. The IV formulation, at least in this country, was discontinued. Now, if you take the oral form with food, that decreases the GI discomfort that this drug can cause, particularly fatty foods. Particularly fatty foods. Please don't encourage your patient to go down to McDonald's and get a Big Mac. That's probably not going to help their waistline. But a high-fat meal will increase the absorption and help you better tolerate this drug. That is pretty well established. Absorption can be erratic, and the reason for this is due to the diarrhea. If you're increasing transit rate through the GI tract, you have less opportunity for absorption. Yeah, you have less opportunity for absorption. So that should make physiological sense to you. But if you decrease the diarrhea by taking it with food, then your absorption usually will be better. So that's something to keep in mind. So drug of choice for treating your dimorphic fungal infections: Histoplasma, blastomyces, coccidioides, those infections as well. Voriconazole. This is a azole that is especially effective against members of the genus Aspergillus. Why is this an issue? Here's why. If you have a patient who works in industry and they inhale a lot of dust, you're going to get types of chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, asbestosis, silicosis, anthracosis, things like that. Or if your patient has had tuberculosis, you'll get cavities in the lung. Aspergillus the spores are very tiny. You can inhale them. They can get into those cavities and they can grow cavities and produce fungus balls. These fungus balls get walled off by the immune system, and they're very, very hard to treat. Extremely hard to get drugs into these cavities with these fungus balls to treat these infections. Voriconazole is a specialty drug that gets in and treats those fungus balls really, really effectively. This drug is very, very effective against Aspergillus. Effective against other types of Candida species as well. Not very good against your zygomycetes, but oh well. Now, this drug has a side effect that is unique to it amongst the azoles, and that's visual disturbances. The patient tends to see wavy lines and flashes, usually in the peripheral vision. Those will tend to go away once they stop taking the drug. The way you ascertain this is there's a sheet. You usually have a visual sheet that's in your flipbook. You can hold that up and you can say, are these lines straight? And the patient will say, they're kind of wavy, they're moving. And that's essentially how you assay for that. Don't be alarmed at this, it'll go away. Also, if you turn the lights off and you do a slit lamp, usually the patient may say, I'm seeing flashes over here. Common, but it'll go away. Don't be alarmed at that. The patient can get really freaked out by this too. So just keep that in mind. There is a cyclodextrin stabilizer that's used with voriconazole. If that accumulates, that can be quite poisonous. That will accumulate in people with decreased renal function. Note this essentially. So be careful in people with decreased renal function. Voriconazole is very good if you have a Candida albicans species that's fluconazole resistant. Voriconazole is very good for that. A lot of drug interactions with voriconazole. It's the first drug of choice for aspergillosis and hepatically eliminated, so don't use for candiduria. That is, if you get a urinary tract infection with Candida, it's not eliminated in urine, so voriconazole is not going to be much help. Posaconazole is a specialty drug for your zygomycete infections. Who gets zygomycete infections? What are zygomycetes? Bread mold. Rhizopus, the bread mold. Bread molds are zygomycetes. People who get these are immunosuppressed, so AIDS patients, cancer patients, people with diseases of the immune system, immunodeficiencies, they'll tend to get these infections. Zygomycete infections are very hard to treat. Posaconazole is your specialty drug for zygomycete infections. And again, rash, nausea, hepatotoxicity, and then drug interactions as well. This drug comes as an oral suspension. So you drink it down. If your patient can't swallow, yeah, that's a problem. You may have to give it via a G-tube in case like that, but you need to give it with food. And high-fat foods and low pH drinks like soda, they will boost absorption. If your patient's on a proton pump inhibitor, that inhibits absorption. As we said, drug of choice for zygomycete infections. And then asuvaconazole, asuvaconazonium sulfate is the PrEP, and this is used to treat invasive aspergillosis and mucormycosis, your zygomycete infections. This drug is relatively new, so there's not a lot of data on it. It's a nasal, so it inhibits ergosterol synthesis. And I just went on to the drug manufacturing site, and here are the side effects. Essentially, they listed. So the biggie, of course, are the GI. effects, and then headache. And then you can see there's cough, edema, back pain. 50% of your patients had serious adverse reactions. This is a pretty toxic drug. You only want to use this if your patient is very sick. This drug was developed for patients for whom those aspergillus infections spread to the blood. So you get essentially a fungemia, and that's septicemia, which is caused by aspergillus fungi in the bloodstream. Again, very difficult infections to treat. This drug was developed for that. And there's multiple drug interactions. Skevin, prodrug. Isavuconazonium is a prodrug. So don't take other drugs that inhibit this cytochrome P450 enzyme. This is a short list of those drugs. It's just, yeah. Check your drug interaction charts. Are there any questions about the azoles? Anything about the azoles that you have questions about? No? Then let's go to the echinocandins. The echinocandins cannot be taken orally. They're given intravenously. The echinocandins inhibit the synthesis of beta-glucan in the fungal cell wall. Our bodies do not have beta-glucans. We don't make beta-glucans. Many fungi do, so that target for antifungal drug development. So echinocandins inhibit the beta-1,3-glucan synthetase that makes the cell wall beta-glucans. And there's 3 of these drugs, and they all end with fungin. So there's caspofungin, micafungin, and anadolafungin. Caspofungin, micafungin, and anadolafungin. So a very silly mnemonic for remembering this is karaoke night in Andalusia, Spain, with Casper the Ghost singing into a microphone. The mic, mica, fungin, Casper, caspofungin in Andalusia, and anadolafungin, what have you. If that helps you remember these, then use my stupid mnemonic. If my stupid mnemonic doesn't help, then find another one that's more helpful. Are any of you familiar with a website called Picmonic? Let me commend Picmonic to you. Picmonic has these pictures, and they're meant to be pictures to help you remember complicated things like pharmacology or physiology or stuff like that. You have to get an account, but there's some stuff they have that's free. And if you browse that site, you might find some mnemonics on there that are pictures. You can download them, and by just staring at the picture, it can remind you of things and help you remember things. Because some of this stuff trying to remember it all is just is ridiculous. But pictures, I know your generation tends to think in images. So that's just something to maybe help you out. So in order for these drugs to work, the fungus has to make beta-glucan. And some fungi make beta-glucan, some don't. Candida species fortunately make a lot of beta-glucan. So do Aspergillus species. So they're very good against these species of fungi. They're effective against some dimorphic fungi, not all. They're also good against some of your zygomycetes. They're not effective against Cryptococcus. Cryptococcus is a basidiomycete, and its predominant carbohydrate is chitin. So they're not inhibited by beta-glucan synthetase inhibitors. Now, the biggest side effect of these drugs is you get a histamine-related infusion reaction. That means when you infuse the drug in, your patient will get this awful itching. Now, can you pre-medicate the patient to prevent that? Sure. So if you give diphenhydramine, if you give them maybe a second-generation antihistamine, cetirizine, loratadine, dexafenadine, Claritin, Allegra, Zyrtec, if those should actually help prevent this infusion reaction. Some patients have hepatotoxicity. That's rare. If your patient has a less than functional liver, you may want to do a pre and post lipid panel to get an idea. Other than that, these drugs have a pretty good safety profile, pretty well tolerated. So caspofungin, micafungin are eliminated by the liver. Andalofungin is eliminated in plasma. So its metabolites then go out of the urine. The beauty of this is that you don't have to adjust these drugs for someone with less than functional kidneys. They're less active against Candida parapsilosis. Use fluconazole instead. You have drug interactions with immunosuppressants like cyclosporin and sirolimus. So patients who are transplant patients, they have to take these. They're also prone to fungal infections. So be careful of drug interactions with immunosuppressants when it comes to the echinocandins. All right. And that's all she wrote on that one. Are there any questions? Stop. Good gravy. Are there any questions about anything we've talked about? Fungals, antifungals, whatever? No? Then let's go ahead and take our 5-minute break. And if you dream up any questions during that time, go ahead and ask them. And we will then continue from there. Okay, people on Zoom, 5-minute break, get a drink, go to the bathroom, smoke them if you've got them.
So I think I answered that one, but then I don't know.
Okay, so there's these 5 answers here.
Mm-hmm.
All right. And okay, you answered it and it didn't give you the right answer?
No, this is what I got thrown at the time.
That's weird.
It's not what it is.
Interesting. Okay, does the envelope play any role in replication?
I thought it like had things on it to like promote.
That's for budding. That doesn't promote it. That doesn't promote it, no. Does it protect the virus from natural selection?
Sounds like it. but
No. No. In fact, the proteins embedded in the membrane are subject to natural selection in a big, big way. Does it aid in the virus' ability to mutate rapidly? Aid? It's a result of the virus mutating, not aiding. Because the mutations occur in the nucleic acids, not in the membrane.
That one's not right.
Right, so that's not right either. Helps hide it from the immune system. That's probably the best answer. Destruction from freezing or thawing? No.
How does it hide it? Is it like protect-
Well, the capsid. Capsids tend to be very immunogenic. The spike proteins will be immunogenic, but membranes, lipids aren't. So that would be your best answer probably.
I think I clicked all of them, but then that wasn't true. And then I got it wrong.
You clicked all, and it said it was wrong? That's the right answer.
I mean,
It's because gamma rays damage DNA badly. They also can produce some really nasty peroxides because they blast lipids in half and they make really disflagellate. Yep, they do that too. Because the electron absorbs the energy, jumps to another shell, and then leaves. So let me check that one. That's quiz 4.
Wait, no, this is
Okay, quiz 3. Well, people have taken this already. Okay, that answer is wrong. That answer is wrong. So, here's what we're going to do. Okay, so that will update. That updates all the attempts, so it will alter your score. Yeah.
And then the small question, I do one question 3. For 4, it was like the I mean,
No. No. Oh, that one? Segmented. Segmented. How's Keegan doing? So she was positive.
No,
She wasn't.
but she has.
Okay.
And
I don't see her
I
on.
know she's
Really? Because these folks are on. Okay, well. Hey, people on Zoom, please tell me if the slides move. Are the slides moving? Are they moving?
Yes, they're moving.
They're moving. Excellent. Okay, thank you. All right, sports fans, shall we continue? It is so encouraging for me to see you guys texting and talking, staying in contact with your colleagues who are quarantined. My youngest daughter, Emily, was quarantined for 2 weeks at Greenville because she had been in close proximity to someone who tested positive. And Emily, my daughter, Emily, is extremely social. And being quarantined for 2 weeks is her idea of hell. And so I think Emily probably calls us once every 2 weeks, if that. She called us every day during her quarantine. She was so long, she was climbing the walls. So if that was that bad for her, I imagine what it's like for your colleagues. But you guys are texting them. I see you guys in lab texting them and doing screen share and what have you, FaceTiming them and stuff like that. That it means a lot to them. Emily had told us that her roommates came to the screen of her window and joked with her for about 20 minutes and kept her up on all the dorm room gossip and so on and so forth. And she told me, she said, boy, it seems silly, but that 20 minutes lasts a whole day. If I just knowing that somebody out there still cares whether I live or die, that really means a lot to me. And since we have one who just got off quarantine, Allison, could you probably give me an amen to that? Amen. So keep your quarantine colleagues, please, in your prayers and keep them in your attention because it makes a big deal. It matters a great deal to them. Also, one other thing. I thought it'd be a nice gesture if we could send Bethany a card. She had to withdraw from this class. It's too much given her time. Would someone be willing to volunteer to buy a nice card? In fact, here, I'll give you money for it. Would someone be willing to do a card and then we could pass it around on Monday? Does anyone have time to go get a card? You are? Okay. Okay, I want to change, all right? Right, so a nice card, we're thinking about you kind of card. If it's silly, that's fine too. Silly's good. Just not crass, okay? Oh, you're kidding. Okay, well then give that to her. Yeah, I'll support a starving college student. Heck yeah. So then Monday, please, and then we'll pass it around and I'll sign it, and then we can get that sent to Bethany. Bethany's mother is head of the radio station here. She's a dear, dear lady. I consider a friend, not a close friend, but definitely a friend. So let's support her as much as we definitely can. Okay, antiviral agents. This slide went this morning. I'm sorry, I was slow on the draw on that one. So if you have your computer, you can bring it up because it's in Blackboard. If not, just follow along. This is new information. It's not, your book kind of runs through these and doesn't give them a very good coverage. So let's talk a bit about antiviral agents. Let's talk first about agents that are used to inhibit herpes viruses. So the herpes infections include HSV 1 and 2, and then VZV, varicella zoster virus, which causes chickenpox. The trend with HSV 1 tends to be this. If it's above this area here, it's HSV 1. If it's below this area here, it's HSV 2. So genital herpes tends to be caused by HSV 2. Labial herpes tends to be caused by HSV 1. Now, can they switch? Yeah, they can. But on the average, if your patient has genital herpes, it's usually HSV 2. If your patient has labial herpes, it tends to be HSV 1 on the average. Can your patient be something other than average? Yes, because we're individuals, we're unique. Remember, herpes has this capacity to hide in neurons. It hides in ganglia. HSV1 hides in the trigeminal ganglia. So your zygomatic arch, beneath that you have the teratogeo fossa. The teratogeo ganglia is beneath that fossa. The HSV1 hides in the neurons of fossa. When you're weak, stressed, immunosuppressed, studying for the NCLEX, studying for this class, had it with a family member, planning your wedding, you know, it's whatever. Patients will get outbreaks. They get blisters usually on the lips or the gums, maybe even on the face. And these blisters, they hurt. They really hurt. HSV2 tends to be the sacral dorsal root ganglia. And they will come out usually in the genital area or in the perineal area or usually in the leg pits or places like that. And then varicella zoster causes chickenpox, and then it becomes latent in the dorsal root ganglia of the sacral area. They come out usually on one side. That is called herpetic zoster, otherwise known as, you put it on your roof, shingles. Thank you. Thank you. Shingles. Shingles. Do only people get shingles? No. No. In fact, you're starting to see shingles more and more often in younger people. So, yes, shingles tends to occur in older people more often, but it can occur in younger people. My oldest daughter, Rachel had chickenpox when she was 2. Church tree, everybody got chickenpox. Rachel had a mild case. Then when she was 13, she had a case of shingles. And it was wraparound, it was on one side. I said, Carolyn, I think that's shingles. And my wife said, she's 13. Don't be stupid. She's 13. I said, I think that's shingles. And Rachel's like, it itches, it burns. So I went to the doctor, and guess what the doctor said? It's shingles. Told my wife, I told you. And then, so it can happen in younger patients. So keep that in mind. So what you do for the patient with really refractory herpes infections. Well, you're in luck because, and the 3 drugs of interest are acyclovir, famciclovir, valacyclovir. Those are the 3 drugs. Valacyclovir is a drug of acyclovir. Acyclovir is not very soluble, so its absorption is poor. Valacyclovir is very soluble, very well absorbed, then in your body gets converted into acyclovir. So it's a pro-drug. And then famciclovir as well. Now, to make DNA, remember, herpes viruses are DNA viruses. To make DNA, you have nucleotides. Herpes encodes its own thymidine kinase. What's thymidine kinase? Thymidine kinase makes nucleotides that will be incorporated into the DNA of the viral genome. Do we have our thymidine kinase? Yeah. But the viral thymidine kinase works faster. Because the virus, you know, got cells to infect, diseases to cause, things to do. So it has a faster thymidine kinase. That thymidine kinase is different from ours. So it's a drug target. That's the enzyme these drugs target, the viral thymidine kinase. By inhibiting that thymidine kinase, you don't make DNA and you kill off viral replication. That's how these drugs work, by killing off viral DNA replication. They do this without affecting our own DNA synthesis. Okay, so these drugs work the best for HSV 1 and 2. They will work for VZV, and they don't work at all against Epstein-Barr virus or cytomegalovirus or HIV. But so these are drugs that are designed for your Hamas, Alabama herpes viruses. Oral acyclovir is extremely well tolerated. There are very few side effects to oral acyclovir. Where you start to get a problem is with intravenous acyclovir, because it can build up in the kidneys and it can precipitate out and it can cause acute interstitial nephritis. Acute interstitial nephritis. And this has to do with acyclovir insolubility. So, patient has severe herpes infection. You have to give intravenous acyclovir. What's the one organ whose function you're going to watch like a hawk? Kidney. Kidney, 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 kidney. Valacyclovir is only given orally, extremely well tolerated. You can also give these drugs prophylactically. So patients who get bad labial herpes, they tend to get tingling in the lips or tingling in the face before they get the lesions. If you take valacyclovir before the lesions appear, when you start to get the tingles, these will tend to prevent the lesions from forming. So they can also be used prophylactically. Famciclovir is only given topically, and it is available as a product called Abreva. That's the one that you use topically on sores and things like that. Any questions about these drugs? Cytomegalovirus is a distant cousin of the herpes viruses. Most people have cytomegalovirus. 60% of Americans, by the time they become adults, are seropositive. You don't know you have it. It doesn't cause any symptoms. If you're immunocompetent, usually it doesn't cause any symptoms. It, however, can cause rather devastating infections in immunosuppressed people, and it can also cause infections in children. Valacyclovir, famciclovir, valacyclovir are not effective against cytomegalovirus. So there are two drugs that are used. There's goncyclovir and there's valganciclovir. These drugs, again, inhibit cytomegalovirus DNA synthesis. They inhibit DNA synthesis of the virus. Goncyclovir can cause myelosuppression. This is dose specific. If it builds up in concentration in the body, it can cause nephrotoxicity. It can also cause hepatotoxicity. Again, that's dose dependent. There are reports of mucosal blisters, again, dose dependent. And there are reports of seizures, again, dose dependent. So is it worth doing blood draws and measuring the amount of this drug in your system? Probably, especially if your patient has a compromised kidney function, compromised liver function, or is prone to seizures. All things to consider. Anti-influenza drugs. So the drug that is most commonly used for influenza is oseltamivir. Oseltamivir binds to one of the glycoproteins on the outside of the virus. So this is a segmented RNA virus. You have embedded in the outer membrane a trimeric protein. This trimeric protein consists of something called a hemagglutinin and a neuraminidase. Oseltamivir inhibits the neuraminidase. So it prevents the virus from being able to infect cells. The virus comes up to host cells to infect and just goes bonk, bonk, can't infect. because oseltamivir is inhibiting this trimeric protein that's used to infect cells. Oseltamivir is oral. You can also give it prophylactically. It only works if it's given early. Zanamivir, trade name Relenza, is an inhaled agent. It's an inhaled agent. It also is a neuraminidase inhibitor. And then peramivir is an intravenous agent. That's Rapivab, also a relatively new product. So the oseltamivir, it's a competitive inhibitor of the neuraminidase because the enzyme cleaves sialic acid that's found on the glycoproteins of the surfaces of cells, helps new virions exit the cell, so it prevents virus particles from being properly released from infected cells, and then the infected cells just present that neuraminidase on the surface of the cell. The immune system then will destroy the infected cell. You don't make any new virus. You don't have a productive infection. This only works in the early stages of influenza, and the patient needs to have not been symptomatic for any more than 48 to 72 hours, and the literature says the earlier the better with this drug. After 72 hours, giving the drug is not efficacious and not recommended. It's only effective against influenza. It's not a substitute vaccination. Let me emphasize that. The big issue with this drug is GI distress. Now, according to the drug insert, the gastrointestinal distress is rare. However, clinicians who use this drug have told me that the GI distress is actually, in their experience, fairly common. So, you know, the drug manufacturer says one thing, clinicians say another. Who are you going to trust? Well, depends. What about zanamivir? Zanamivir is inhaled. Because it is inhaled, it can cause bronchospasm and coughing, and therefore it is contraindicated in patients with asthma. Oh, there it is. What about peramivir? This drug, again, is pretty new. The two side effects that have been reported are diarrhea and neutropenia. There is a drug that was approved end of last year. It's very new. It's called baloxavir. This has a completely different mechanism of inhibition. This inhibits the viral RNA polymerase. Baloxavir is oral, and apparently it's better tolerated than oseltamivir. So baloxavir may become a drug that is used, more often than oseltamivir. Neuropsychiatric events have been reported with oseltamivir, but it's very not clear at all if that those neuropsychiatric events are related to the drug because they're so rare. So those reports are not really taken very seriously. Any questions about the anti-influenza, antiherpetic drugs? Good? All right. Oh boy. All right, let's try this again. Not me, really. Okay, people on Zoom, are the slides moving?
Yes, they are.
They are? Okay, very good. Okay. Now let's look at drugs that are used to treat HIV. So with HIV, you have a retrovirus. So you have an RNA genome, but the virus has a reverse transcriptase that converts that RNA into DNA. And it does this in the nucleus. That DNA is then integrated into the genome of the host cell. And the enzyme that performs that function is called an integrase. Then you're going to produce viral proteins. The production of viral proteins requires the activity of a viral protease. Proteases are enzymes that clip other proteins. So if you have a protein that's this big, a protease will come and clip. Now you have two proteins, one this big, the other this big, instead of one that was formerly this big. That's what proteases do. They clip other proteins into smaller polypeptides. So you have a viral protease, you have a viral integrase, you have a viral reverse transcriptase. These are all potential targets for chemotherapeutics. Then the virions are going to bud from the host, and you're going to lyse the host cell. So you have some drugs that may inhibit this stage. Also, the virus will initially fuse with a cell. You may have drugs that inhibit that as well. So the life cycle of HIV represents genuine targets for chemotherapeutics. And this is just taken from the NIH website, and it shows you the attachment, the receptor for HIV, extremely well characterized. It's a CD4 protein on helper T cells. There's also a co-receptor called CC5, CCR5. And then you get fusion of the membrane of the virus with the host cell membrane. The capsid is then uncoated. The viral RNA is taken to the nucleus. You get reverse transcription of the RNA into DNA, integration of the DNA into the host genome. Then you start making viral RNAs. Those are translated, transcribed, translated. You then get the assembly of virion particles using the viral PAs, and then you bud the virus from the cell to go infect other cells. So here is an HIV capsid. You have a membrane that's derived from the membrane of the host cell. You have a so-called GP120, which is a viral glycoprotein that will dock with the CD4 receptor. You have a GP41, that is a little stem that inserts it into the membrane. Beneath the membrane, you have a so-called M protein, matrix protein. And the matrix protein, excuse me, the matrix protein supports the membrane, and inside that you have the capsid. The capsid houses the RNA. With the RNA, you have 2 copies of the RNA per virus. You have the reverse transcriptase in this as well. And other proteins are made during the life cycle of the virus. The genome, the genes are all well mapped. GAG stands for group antigen. Group antigen. Why they get the unfortunate acronym GAG? I don't know. But group antigen, that's why it's called GAG. That includes usually elements of the nucleocapsid and what have you. And then the integrase, reverse transcriptase, protease, that's all part of the Paul gene. The envelope is the GP120 and the GP41. And then other elements of the group antigen form capsid, nucleocapsid, and then matrix protein as well. All right, let's take a look then at some of these agents. So there are agents that inhibit the reverse transcriptase. Now, remember this. When you treat a patient with HIV, you always treat them with a multi-drug cocktail. You'll never, ever, ever treat them with one drug. It will be a multi-drug cocktail. Those cocktails will almost always include at least one reverse transcriptase inhibitor, maybe 2. Maybe 2. There are drugs that inhibit viral entry into cells. They inhibit fusion of the virus with the host membrane. Then there are drugs that inhibit the integrase. So they inhibit viral integration of the viral DNA into the host cell genome. Then there are drugs that will inhibit the protease involved in maturation of the virion particles. So you have reverse transcriptase inhibitors. There are 2 groups of these. There are so-called nucleoside analogs. Nucleoside analogs. These drugs, when they enter the cell, they get a phosphate stuck on them so they can't escape from the cell. There are artificial nucleosides. They get incorporated into the viral DNA. And they prevent conversion of viral RNA into viral DNA. Those are the nucleoside analogs. And then there are non-nucleoside analogs. These bind to the reverse transcriptase and inhibit it. The non-nucleoside analogs are very susceptible to resistance. So if you use them, you have to combine them usually with another drug to get around the resistance. So your nucleoside inhibitors are shown here. So there's tenofovir, Evidine, which is second line because it's quite toxic. Cidovudine, also very toxic, second line. And Tracidovine, Lamivudine, Abacavir, Didanosine, also very toxic, second line, and Zalcitabine. Those are the nucleoside reverse transcriptase inhibitors. They get incorporated into the viral DNA and terminate synthesis. So here's your viral RNA. You're trying to make DNA. You incorporate these and you terminate that synthesis. So viral replication is stopped in its tracks. This drug here, Lamivudine. Lamivudine is also active against hepatitis B. It's also active against hepatitis B. Same with tenofovir. Tenofovir is also active against hepatitis B. And so those two drugs overlap with HIV and hepatitis B. So the adverse effects of these drugs are unfortunately manifold. Even though they have a high affinity for the reverse transcriptase, some inhibition of endogenous polymerases is inevitable. So GI disturbances, nausea, vomiting, diarrhea, very common. Very common. Bone marrow suppression, anemia, neutropenia, very common. CNS toxicity, insomnia, headaches, and peripheral neuropathy, so relatively common. And some metabolic effects, unfortunately, such as lactic acidosis. The nephrotoxicity is usually the case with the more second-line drugs. Tenofovir, however, does show substantial nephrotoxicity. So that one, which is in some cocktails, you really want to watch kidney function with that drug. Oh boy. All right, according to Mickey over there, we're out of time. Talk a bit about the drug combinations next time. Get into the non-nucleoside RT inhibitors. I put together this handout for you guys on antivirals. I haven't handed it out yet because I'm still looking through it for mistakes. because I always make mistakes when I type. I will email this to you so that you can bring this to class next time. It'll save you from having to write so much. All right? And gang, if you have any questions as you study over the weekend, just email the questions to me, okay? And that goes for you also on Zoom. All right. I'll take your lab books if you're done with them. Do I have any what? Oh, just put on the table, yeah. Yeah. Thank you. Okay, Zoom folks. Stay well, and hope to see you guys on Monday. Karis, when is your quarantine finished?
It's done this evening, so I'll be back on Monday.
Okay, and Dalen, you just went on quarantine, right?
Yeah, they're allowing us to come back on campus next Wednesday and then attend classes Thursday.
Do you have to get tested first, or?
I got tested like last Friday, and I was negative. And then ever since then, I haven't been in contact with anybody.
Okay, you feeling all right?
Yeah, I have no symptoms. I feel great.
You feel great. Okay, well, hopefully see you back soon then. Do take care of yourself, all right?
Thank you.
Okay. All right, guys, have a great weekend.
You
Ciao.
too. See ya.